Hello and a warm welcome to everyone to our today's webinar on multiple myeloma, opportunities and challenges in changing treatment landscape. I am Bhavika Maheshwari and I represent Veeda Group. Before we begin, I will just introduce you to Veeda Group once. What is Veeda Group? What do we do? Veeda Group offers you comprehensive services of preclinical, clinical, and bioanalytical services. We have helped our global clientele in drug development programs for innovators, biosimilars, and generics. We have an extensive network of key opinion leaders across 26 geographies. Vida Group has become a trusted drug development partner, delivering exceptional results on a global scale. Together, we serve our global clients in pharmaceutical, biopharmaceutical, agrochemicals, and industrial chemicals, herbals, nutraceuticals, and medical devices industries. As your facilitator today, I would like to introduce you to a couple of points before we begin the session. This session will have a presentation in the beginning, which will be followed by a Q&A round. We have also enabled the Ask a Question feature. You can drop all your questions related to the webinar over there. And now, moving forward, I would like to introduce my panelist for the day, Dr. Stavros Goklinopolis. Dr. Stavros is a medical oncologist. He has an experience of approximately 13 years as a physician, clinical trial investigator, and clinical scientist. He has a very diverse background. He has worked in general hospitals, cancer centers, and CRO companies. He has particularly focused on anti cancer drugs during his clinical research and trials career. He is currently serving as Associate Director and Global Safety Physician in Vida, Europe. Dr. Stavros holds a master's degree in neoplastic diseases in humans. He also has an MBA degree in healthcare management. He has earned an honorary distinction in the 2 year educational program of the Hellenic Academy of Oncology. Well, this is not it. He also has 53 publications, including peer reviewed journals, articles, abstracts for national and international congresses, oral and poster presentation. His medical expertise is in solid and hematologic malignancies, clinical development of anti-neoplastic drugs, clinical trials, safety signal identification, risk mitigation. He is well versed in health economics, particularly in clinical trials. So, without any further ado, I would like to virtually call upon Dr. Stavros to begin the session for the day. Dr. Stavros?
Thank you very much, Bhavika, for this very nice introduction. And thank you also for this opportunity to present some very exciting recent developments on multiple myeloma management. So let us begin by having a look at the agenda of our webinar. We will briefly discuss some key points of multiple myeloma. Then we will review the changing treatment paradigm in transplant eligible and transplant ineligible patients. And we will touch upon some very interesting data about some new options at first relapse. Then we will discuss about MRD, which is a recent addition to the endpoints for clinical trials and a very successful one, I may add. Furthermore, we will discuss about the opportunities and the challenges that these new developments bring. And finally, we will close this session with some take-home messages and, of course, your questions and our answers. So, to begin with, multiple myeloma is an hematologic malignancy of plasma cells that accumulate in the bone marrow, causing bone destruction, cytopenias like thrombocytopenia and anemia, and damage in multiple organs and systems such as the kidney and the bones. It is mainly a disease of older individuals, affecting people of between 65 and 74 years old, with the median age at diagnosis being 69 years old. In terms of incidence, it is ranked in the 21st place among all solid and hematologic malignancies, with approximately 188 new cases diagnosed in 2022 on a worldwide level. In terms of mortality, it is ranked in the 17th place, with approximately 121.5 deaths recorded in 2022, again on a worldwide level. It seems that the incidence rate of multiple myeloma is projected to increase in the following years following the increase in life expectancy. On the contrary, mortality rates are projected to drop, mainly as a result of the advent of new therapeutics that have transformed the therapeutic landscape of multiple myeloma during the last few years. As an example, in the United States of America, between 2001 and 2021, the age-adjusted incidence rate has increased by 24%, while the death rate has decreased by 23%. As a result of the demographic transition, global population is aging rapidly, and this phenomenon is observed in regions with relatively youthful populations, such as Africa and Western Asia, which are expected to experience the fastest growth in the number of older people over the next 3 decades. In 2021, for example, one in 10 people worldwide were aged 65 years old or above. In 2050, this age group is projected to account for 1 in 6 people globally. In other words, the number of people aged 65 years or older worldwide is projected to more than double, rising from 761 million in 2021 to 1.6 billion in 2050. As a result, multiple myeloma is expected to affect a substantially higher percentage of individuals in the following years, and this increased incidence will severely affect countries that now have relatively low prevalence of this disease because, as already mentioned, they have youthful populations and multiple myeloma is a disease of older individuals. So, what will this increase in the incidence rates of multiple myeloma will bring? A lot of challenges. There will be increased need for novel drugs and treatment regimens. There will be an increased demand for a more personalized treatment approach. And of course, there will also be a need for more cost-effective treatment strategies. The increased incidence of multiple myeloma will be a burden on healthcare systems as well as on the patients and their caregivers, resulting in substantial productivity loss. So, a multidisciplinary approach is absolutely necessary to effectively face these challenges, and clinical trials will be at the front and center of this process. But what do we have in our therapeutic armamentarium? Preclinical research has identified a number of small molecules and molecular pathways that can be used to target multiple myeloma. Clinical research has revealed that the best way to battle multiple myeloma is to combine drugs with a different mechanism of action. So, it will not be an exaggeration if we could say that there are four pillars of multiple myeloma treatment. There are, of course, the immunomodulators, the antibodies targeting the CD38 molecule, the proteasome inhibitors, and various drug categories that target BCMA, such as the bispecific antibodies, the antibody drug conjugates, and the CAR T cells. Historically, newly diagnosed multiple myeloma patients were categorized into two broad groups depending on whether autologous stem cell transplantation would be part of their initial treatment: the transplant eligible and the transplant ineligible patients. This categorization is made on the basis of the patient's age and comorbidities and is assisted by various tools that measure the patient's ability to withstand autologous stem cell transplantation, such as the IMWG frailty score. Furthermore, these two populations may further subdivided based on other parameters, such as the presence of high-risk disease features, such as high-risk cytogenetics or extramedullary disease, and their fitness for more intensive therapy. Let us begin with transplant-eligible patients. The main goals of treatment for transplant-eligible patients is to provide rapid, deep, and durable responses in each stage of the transplantation process. This ensures long-term disease control and improved survival outcomes. So, for induction therapy, the most commonly used treatment regimens have been triplet therapies consisting of an immune modulating agent, a proteasome inhibitor, and dexamethasone. Compared to a doublet regimen, the triplet therapy offered improved survival, improved responses, and manageable toxicity. Consequently, doublet regimens are not recommended anymore as induction treatment. Instead, triplets such as the VRD regimen, the KRD, and the VCD regimens have been the standard of care for many years. In recent years, there has been an interesting development in CD38 targeting in preclinical and phase 1 and 2 clinical studies that have provided promising results. It has already been established that triplet therapy is better than doublet therapy in terms of efficacy. So, the question arises, can quadruplet therapy offer more? In that regard, several studies have been conducted and provided promising results in transplant-eligible patients. Currently, there are two monoclonal antibodies that target CD38, daratumumab and isatuximab. And you can have a look at some of the large phase 3 trials conducted to evaluate quadruplet combinations over triplet combinations. Let's have a look at the most influential one, the Perseus study. This study randomized 709 transplant-eligible patients to receive induction and consolidation treatment either with the DARA-VRD regimen or with a VRD regimen. In this study, daratumumab was given subcutaneously. Maintenance was either with DARA lenalidomide or with lenalidomide, while DARA was discontinued for MRD negative patients. The primary endpoint was progression-free survival, and key secondary endpoints included the MRD negativity rate and the overall survival. Let's have a look at the PFS. At a median follow-up of 48 months, the PFS rate was a statistically significant 84.3% versus 67.7%. As a result of this trial, the DVRD regimen is a category 1 preferred regimen in the NCCN guidelines, along with other recommended regimens such as triplet regimens that had been the standard of care for many years up to the emergence of quadruplet regimens. So, does this apply to transplant-ineligible patients as well? Let's have a look first at the goals of treatment. Transplant-ineligible patients may be further subdivided to fit and frail, with different treatment goals and different priorities for each category. For fit transplant-ineligible patients, the main goal of treatment is to improve the MRD negativity rates. In this way, to improve survival parameters such as progression-free survival and overall survival. Of course, improving quality of life parameters is also an endpoint for this category of patients. For frail transplant-ineligible patients, instead, improving quality of life parameters is of utmost importance, perhaps of even greater importance than improving survival parameters, such as overall survival and progression-free survival. In this way, we may limit treatment-induced toxicities and complications arising from multiple myeloma, perhaps even transform frail patients to fit ones, fit for more intensive therapy, and in this way for better survival outcomes. Let's have a look at the MAIA trial. The phase 3 MAIA study randomized 737 transplant-ineligible patients to receive daratumumab plus the backbone of lenalidomide and dexamethasone, or the backbone alone, and treatment was to continue until disease progression or unacceptable toxicity. In this trial, daratumumab was given intravenously. The primary endpoint was PFS, and key secondary endpoints included the MRD negativity rate, the complete response or better rate, survival, and time to progression. Following on the trend of the previous studies comparing triplets with duplet therapies, we once again have a statistically significant PFS benefit for the triplet combination of DARA-RD versus RD alone. And this statistically significant benefit was observed in most subgroups, with a notable exception of patients with high-risk cytogenetics. So, we know that triplet therapy is better than duplet therapy in terms of efficacy in transplant-ineligible patients. But what if quadruplet therapy is better than triplet therapy in this category of patients as well? In the phase 3 IMROS study, 446 transplant-ineligible newly diagnosed multiple myeloma patients were randomized to receive either isatuximab plus VRD or VRD alone. The primary endpoint was progression-free survival, and key secondary endpoints included MRD negativity rate, complete response or better rate, and safety, of course. At a median follow-up of approximately 60 months, the estimated PFS was 63.2 in the isatuximab VRD group versus 45.2 in the VRD group, a statistically significant difference. And the percentage of patients with a complete response or better was also significantly higher for the ISA VRD group versus the VRD group, as was the percentage of patients who were MRD negative and had also complete response. So the IMROS study established that the ISA VRD quadruplet therapy was better than the VRD therapy. But what was the actual benefit of the proteasome inhibitor in the quadruplet therapy? In that regard, we have the benefit study. The phase 3 benefit study randomized 270 transplant-ineligible newly diagnosed multiple myeloma patients to receive the triplet ISA-RD versus the quadruplet ISA-VRD. The primary endpoint was the MRD negativity rate at 10 - 5, by next-generation sequencing at 18 months from randomization. And key secondary endpoints included the response rate, the MRD assessment rates, the survival, and the safety. The 18-month MRD negativity rates were reported in 35 patients in the ISA-RD arm versus 71 patients in the ISA-VRD arm. And the MRD benefit was consistent across all pre-specified subgroups and was already observed at 1 year. Regarding responses, complete response or better rate at 18 months was higher with the ISA-VRD, as was the proportion of MRD negativity of patients with MRD negativity and complete response or better. So, quadruplet therapy with the ISA-VRD regimen has also been included in the most recent update of the NCCN guidelines as a preferred regimen for the treatment of this patient category. To sum it up, we have a new treatment paradigm for transplant-ineligible patients. For fit transplant-ineligible patients, a quadruplet regimen is recommended, while for frail transplant-ineligible patients, a triplet regimen or a duplet regimen for very frail individuals is recommended instead. And of course, proper patient selection is needed to optimally treat this subgroup of patients. Let's proceed to review some new options at first relapse. Following first relapse, we have a plethora of different regimens available. For fit patients, triplet regimens, once again, are preferred over doublets. The main criterion for treatment selection following relapse is the level of refractoriness to a specific drug. As you can see in the NCCN guidelines, there is a great variety of different regimens combining in different ways proteasome inhibitors, immunomodulators, anti-CD38 antibodies, and other drugs for patients at first relapse. The question is, in the era of quadruplet regimens at first line, where patients have already been exposed to anti-CD38 antibodies, proteasome inhibitors, immunomodulators, and dexamethasone, of course. What remains to treat these patients with following the first line? We have some very interesting options in that regard. And you can see that one of these options has already been included in the NCCN guidelines. This is the CAR T cells, which was recently approved for patients who have progressed following the first line of therapy and are lenalidomide refractory as a result of the phase 3 CARDITUDE study, CARDITUDE 4 study. The phase 3 CARDITUDE-4 study compared a single infusion of cilta-cel versus standard of care regimens at second line, like DPD or PVD, in 419 patients with lenalidomide refractory multiple myeloma who had received 1 to 3 prior lines of therapy. And these are the impressive PFS results at a median follow-up of approximately 16 months. As you can see, for the cilta-cel group, the median PFS was not reached, while it was approximately 1 year for the comparators. That was a statistically significant and a clinically relevant difference between these two groups that led to the approval, to the FDA approval of cilta-cels for patients that progressed following first line and were lenalidomide refractory. Just a few weeks ago, in this year's IMS Congress, a pre-specified overall survival analysis showed that median OS was not reached in either the cilta-cel or the standard of care regimens at a median follow-up of 34 months. The 30-month overall survival rates were 76% versus 64% in these arms, and the OS benefit was sustained across all pre-specified subgroups. The successful results of this trial continued with the other efficacy points, where we have a complete response or better rate of 77% versus 24% for the comparators, an overall response rate of 85% versus 67%, and an MRD negativity rate of 62% versus 18%. And of note, this was the only CAR-T cell therapy that up to this date that has shown a survival benefit. These are impressive results. However, CAR-T cells are not available worldwide, and there are certain limitations in their use, mainly due to logistical reasons. Let's have a look at another option for first relapse. Belantamab mafodotin. That is a first-in-class antibody-drug conjugate, which comprises of a humanized IgG-K1 monoclonal antibody conjugated with the cytotoxic agent monomethyl auristatin F. In the DREAM2 study, belamaf has demonstrated important efficacy in heavily pretreated patients with relapsed or refractory multiple myeloma who had received 4 or more prior lines of therapy. However, in the phase 3 DREAM3 study, belamaf failed to prove superiority over pomalidomide and dexamethasone in terms of PFS prolongation, which was numerically superior but not statistically significant. That was not the end of the story for belantamab mafodotin, though. In this year's EHA Congress, the results of the phase 3 DREAM7 study were presented. In the phase 3 DREAM7 study, 494 relapsed refractory multiple myeloma patients who had received at least one prior line of therapy were randomized to receive belantamab mafodotin with bortezomib and dexamethasone or daratumumab with bortezomib and dexamethasone. The primary endpoint was progression-free survival, and key secondary endpoints included response duration, MRD negativity status, and overall survival. At a median follow-up of 28.2 months, the median PFS was approximately 3 times higher in the belamaf-containing treatment regimen than in the daratumumab-containing regimen. While also the overall survival at 18 months was 84% in the BVD group and 73% in the DVD group. CR or better plus MRD negativity occurred in 25% of the patients in the BVD group and 10% of the patients in the DVD group. Regarding safety, grade 3 or higher adverse events were observed in approximately all of the patients in the belamaf-containing regimen and 78% of the patients in the DVD group. Ocular adverse events, as expected, were more common in the belamaf group than in the DVD group, but were managed with dose modifications, dose delays, and they mostly resolved. Additionally, the phase 3 DREAM8 study was presented in this year's ASCO Congress. In this study, 300 relapsed refractory multiple myeloma patients who were previously treated and exposed to lenalidomide were randomized to receive belamaf, pomalidomide, and dexamethasone, or bortezomib, pomalidomide, and dexamethasone. The primary endpoint was, once again, the progression-free survival, and key secondary endpoints including the response and safety. This trial succeeded in providing a statistically significant and clinically meaningful progression-free survival for the belamaf-containing regimen. At a median follow-up of 21.8 months, the 12-month estimated PFS with the belamaf-containing regimen was 71%, while for the bortezomib-containing regimen was 51%. Regarding the secondary endpoints, uh, overall response rate was reached in 77% of the patients in the belamaf-containing group, as opposed to 72% in the bortezomib-containing group, while complete response or better was achieved for 40% of the patients in the belamaf-containing group versus 16% of the patients in the bortezomib-containing group. Once again, grade 3 or above adverse events were higher in the belamaf-containing group, and ocular adverse events, of course, were also observed here, but were also managed with dose modifications, dose reduction, dose delays, and very few patients discontinued the study due to belamaf-related ocular adverse events. Presently, belladamine mafotodine is recommended as is regarded as useful in certain circumstances for patients who have received at least 4 prior lines of therapy in the NCCN guidelines. But drawing from the results of the DREAM7 and DREAM8 trials, the investigators suggest that belamaf-containing regimens will probably be the next standard of care for patients at first relapse. Let's proceed to have a look at the minimal residual disease, which now is officially a novel endpoint for clinical trials. Minimal residual disease refers to the very small amount of myeloma cells that remains following treatment. And it is assessed in the bone marrow by very sensitive techniques, such as next-generation flow and next-generation sequencing. In recent years, the importance of MRD assessment has been established, and MRD has been at the front and center of hemato-oncology studies as the prognostic role of MRD negativity was gradually being established. The most influential of these studies is a large meta-analysis that showed that MRD negativity predicts progression-free survival and overall survival, even in patients that achieve complete response. In this meta-analysis, 44 studies with progression-free data from 5,000 patients and 23 studies with overall survival data from 4,000 patients were identified to assess the association between MRD status and survival outcomes. Compared with MRD positivity, achieving MRD negativity improved progression-free survival and overall survival in a statistically significant way. What is notable is that the association between MRD negativity status and progression-free survival and overall survival was observed in all pre-specified subgroups, such as newly diagnosed patients, transplant eligible and transplant ineligible alike, relapse refractory multiple myeloma patients. It was observed in patients with high cytogenetic risk abnormalities and patients with standard risk, and it was also evident irrespectively of the MRD sensitivity threshold and irrespectively of the method of MRD assessment. The importance of MRD has been included in the revised response criteria for multiple myeloma. And following these studies and this meta-analysis, recently, the Oncologic Drug Advisory Committee unanimously voted in favor of using MRD as an early endpoint for accelerated approval in multiple myeloma clinical trials. This decision may have enormous impact in the design and conduct of our clinical trials, as this approval may lead to a rapid expansion of the available anti-myeloma treatments, faster uh, conduct of multiple myeloma clinical trials, and perhaps it will even provide us with a more evidence-based and precise approach on how to better use these new drugs, these new treatment regimens, and of course, this will also help their approval by the regulatory authorities. And by this, um, we have reached the penultimate section of our webinar to review the opportunities and the challenges that these exciting new developments may bring. To sum it up, recent studies have demonstrated the superiority of 4 drugs regimens over 3 drug regimens in terms of efficacy um, as first-line treatment in both transplant-eligible and transplant-ineligible patients. Additionally, the treatment options for patients at the relapse also expands with belantamab photodine regimens being an attractive option for these patients in the absence of CAR T cells therapies. This new era of multiple myeloma treatment may bring many opportunities for improving our patients' care, but it may also bring several challenges that need to be addressed effectively to ensure that we may secure the optimal benefit from the expansion of our therapeutic armamentarium. Let us have a look at the opportunities. With the advent of these new treatment regimens, the following opportunities may unfold. Both transplant-eligible and transplant-ineligible patients will manifest improved survival outcomes. Quality of life parameters may also improve, as deeper, durable responses may result in fewer multiple myeloma-related complications. Additionally, the productivity loss that the patients and their caregivers experience may also be reduced. In this way, financial toxicity for the healthcare systems and society as a whole is also expected to drop. Furthermore, with the implementation of the MRD status as a valid clinical trials endpoint for the approval of new drugs and regimens, the following opportunities unfold. We will have faster execution of clinical trials, and this will probably result to a substantial saving of resources. Additionally, we will have faster approval of new medicines, as these trials will take less time to be completed as the more conventional ones with survival parameters such as PFS as their primary endpoints. But what about the challenges? Well, during the implementation of the new quadruple regimens in clinical practice, the following challenges may arise. There will probably be an increased rate of infections for patients who are treated with 4 drug regimens, and also an increased rate of hematologic toxicity like neutropenias and thrombocytopenias and anemia. The cost of treatment will be higher, and this will also lead to an increase in health disparities, as novel therapies may not be available for all, everywhere in the world. Finally, we have the challenge to face novel toxicities, such as cytokine release syndrome and neurotoxicity, ICANS for CAR T cells. We have ocular adverse events for belamaf, And we need also to learn to effectively address these novel adverse events. What can we do to mitigate the risk these new challenges bring? Well, first of all, we need to carefully select our patients on the basis of the logic of one size does not fit all. This means that not every transplant-ineligible patient is eligible to receive quadruplet therapy. There are fit patients, there are frail patients, and there are patients in between. We need to carefully select our patients in order to um, in order to provide them with the optimal benefit of the quadruplet regimen. Also, we need to be vigilant in administering the proper prophylaxis to mitigate the risk of infections. For example, we need to consider immunoglobulin replacement therapy for all patients with IgG levels below 400, and perhaps we should also administer immunoglobulin replacement therapy for all patients who receive anti-CD38 monoclonal antibodies. We should not forget the conventional means for prophylaxis for infections, such as vaccinations, of course, and the administration of concomitant antibiotics, such as cotrimoxazole, and antivirals, such as valacyclovir, for preventing VZV reactivation or opportunistic infections from pneumocystis jirovecii. Furthermore, we should vigilantly monitor CBCs in patients who receive intensive treatment with 4 drugs or even with 3 drugs to prevent cytopenias, especially neutropenia, and administer growth factors such as GCSF whenever applicable to mitigate the risk of febrile neutropenia. Finally, we need to make certain that all patients that need these novel therapies have access to them. We need to battle health disparities on a worldwide level. And in that regard, other disciplines, in addition to medicine and hematology and oncology, will play an active role in this, such as health economics, economic evaluations, cost effectiveness analysis, health technology assessments will provide the necessary evidence to the powers that be, to the decision makers, to the regulatory authorities that yes, indeed, these are expensive treatments, but on the other hand, they are cost effective as well, because they reduce the productivity loss, they reduce healthcare resources utilization arising from adverse events, from multiple myeloma complications, and in the end, these new treatments may be beneficial for the patients, for their caregivers, for the taxpayers, for society as a whole. Finally, we should never forget to administer supportive care in a timely manner to whoever needs it. And who needs supportive care? Everybody. Transplant-eligible patients, transplant-ineligible patients, newly diagnosed patients, relapsed patients. Everyone needs proper supportive care from the time of diagnosis, during the treatment, to the follow-up phase, from the start. So we should never forget that. Support is of utmost importance in addition to our anti-myeloma drugs. And let's move to the final section of this webinar. And have a look at some take-home messages. Well, indeed, recent studies for both transplant-eligible and transplant-ineligible patients have changed the therapeutic landscape for multiple myeloma, offering improved survival outcomes. Additionally, the MRD approval as an early endpoint for the approval of novel drugs and regimens is a major step forward. Now we have the opportunity to expand, to capitalize on these developments and further improve our clinical practice and, by extent, patients' outcomes. To do that, we need to proactively address all foreseeable challenges and work, all of us together, in parallel, as a team, because multiple myeloma and cancer in general is not a problem of just the patients and their caregivers. Is a problem for everyone, as a matter of fact, because as we have already seen, it leads to financial toxicity. It leads to healthcare resource utilization, to productivity loss. So this is a problem for us all. So we should face it together, everyone, every last one of us. And with this, my presentation is concluded, and I am open to questions. Thank you very much for listening to me.
Thank you so much. Now, moving forward, we have some amazing questions here, and I would like you to answer two, three of them right now. How do you
Sure, absolutely.
decide? Yeah. How do you decide if transplant ineligible patients should receive quadruplet or triplet upfront therapy?
Thank you for this question. This is a very interesting question, and it's not very easy to answer actually, because um, as was already mentioned, patient selection is key. But what does that mean? It means that regarding transplant ineligible patients, these can be further subdivided into two broad categories: into fit
Mhm.
transplant ineligible patients and into frail transplant ineligible patients. And um, who is to decide who is fit and who is frail? Well, to begin with, there are some tools that may aid this decision, such as the IMWG frailty score, or the ECOG performance status, the Karnofsky performance status. And of course, we have, our clinical judgment. Um, we we need to have a good physical. We need to have a good medical history from our patients. We need to perform uh, the correct. We need to ask the right questions. We need to ask the right questions, and we need to perform the correct lab tests, such as just a simple CBC and clinical chemistry will reveal whether our patients have a reduced kidney function, an impaired hepatic function, and of course, the patient's comorbidities are also very important to guide this decision, because, as we have already discussed, these are older individuals, and older people, unfortunately, tend to have many health issues. They may have high blood pressure, they may have diabetes, dyslipidemia, and well, all these medical conditions may cause an impaired kidney function, and multiple myeloma may also cause impaired kidney function, and of course, this can be very difficult to discern between these two. So, to sum it up, there are tools that may help to guide us to decide who is fit enough to receive quadruplet therapy and who is not fit enough should receive triplet therapy or even doublet therapy, as in the past. But essentially, our decision should be individualized. Like I said, one size does not fit all. And
Mhm.
the physician's clinical judgment is extremely important to aid a decision. Of course, we should never forget the patient's preferences because we should always ask the patients um, what, how do they like to proceed with the treatment because um, the treatment is a shared decision between the patient and the physician. It is not something that only the doctor decides. There may be patients who prefer not to have a more intensive treatment, and we should always listen to our patients. But yeah, this is a complex decision, and I trust that moving forward, we will observe the emergence of new tools and algorithms and guidelines that may guide us on how to decide um, um, who is fit to receive a four drugs regimen and should receive for their own benefit three drugs or even a doublet. Yeah, that's it.
Great, great. My second question is, in the Dream 7 and Dream 8 studies, there was a very high rate of ocular adverse events. How do you manage this ocular toxicity?
Well, that's a very interesting question. Um, yes, you are correct. Indeed, in both these studies, there was a very high incidence of ocular adverse events, mainly dry eye related toxicity, because ocular adverse events are the most common adverse events of belladamab mafotodine, and the main reason for those modifications and those delays. We know that from um, the first belladamab mafotodine studies, such as the Dream 2 trial and Dream 3 trial, and of course, we have seen this in the Dream 7 and Dream 8 trials as well, as expected. Well, uh, the good thing is that these oculitis events are reversible. Almost all of them are reversible. And even though they do manifest in the majority of the patients, it is important to note here that the vision-related daily functioning of these patients is not substantially affected. And this is manifest from the global analysis of quality of life of the Dream 8 study, because it showed that even though these patients have oculitis events, these events do not substantially impact their quality of life. So this is one thing to consider. The other is that as the investigators of these studies have suggested, uh, ocular adverse events are properly managed with dose delays and dose modifications and dose reductions and extension of the dosing schedules. And all these ways to manage ocular toxicity seem to be uh, very effective on one hand, and on the other hand, and this is quite important to note, is that beladamab mafotodine dose modifications do not negatively impact efficacy. And I think this is very important to remember that beladamab mafotodine uh, provides durable responses, provides deep responses in patients who respond. And even though if we delay a dose of belamaf, even for many months due to an ocular adverse event, this will not have an impact, a negative impact on efficacy outcomes. So, to answer your question with a simple word, actually, the question is how do you manage um, um, ocular adverse events? And the answer is very simple: education, education, because um, we need to educate everyone involved in the treatment process of with this of belamaf containing treatment regimens. Everyone needs to be educated. The physicians need to be educated not to worry about ocular adverse events. They need to be vigilant. Yes, they need to be vigilant. They need to treat these adverse events. They need to consult ophthalmologists. They need to perform the necessary modifications on the treatment schedule, on the dose of the drug, and in general, carefully monitor their patients. But they should not worry that because most of the times these ocular adverse events are reversible, and also they do not negatively impact efficacy. Also, we should educate the patients um, to know. We should let them know that what is the main adverse event of this particular drug. We should let them know what to expect, that they may experience blurred vision, they may experience foreign body sensation in the eye, in general, dry eye disease-related symptoms. But we should also let them know that all data up to this point show that this will not impact their daily routine in a substantial way. So education is a proper response to this question.
Got it. Thanks a lot. My third question is, moving forward, what do you think is the biggest challenge coming from these new developments?
Thank you for this. I think that this is the most complex of the questions you asked me. Um, I would have to provide the same response I gave in your last question. So once again, I think the response to your question is education, because yeah, uh, these new drugs, these new regimens may offer challenges to everyone involved, may offer toxicities, novel toxicities, more toxicities, adverse events. And there are also different ways of administering these, of modifying the treatment schedule, such as belamaf, to mitigate these risks. And the main challenge we face today is to educate everyone involved in the treatment of multiple myeloma patients on how to best use these weapons in our therapeutic armamentarium. Let me give you an example. Um, in your first question, we were actually discussing about how to discern, how to distinguish fit from frail transplant ineligible patients. And in order to make an informed decision, you need to have all the necessary information, of course. And to have all the necessary information, you need to have proper education on the adverse events, education on the results from the clinical trials, such as the ones that we discussed earlier, in education about the data provided by real-world studies, phase 4 clinical trials. And in this way, you may be able to uh, distinguish, to decide actually how to treat every patient. And the same applies to the patients, the same applies to their caregivers. They need to be informed. They need to be educated about these new developments. Otherwise, there is always the moral hazard of receiving less treatment uh, than less treatment than they are able to withstand or they are eligible for, and or they may even receive more treatment than they should. And um, we should also educate, as I mentioned earlier, the decision makers, the regulators, the ones who actually approve the compensation of these novel drugs and regimens. And how do we do that? We do that by having um, having the necessary tools, so to speak, like the HTA assessments, cost effectiveness analysis, the novelty of these new drugs, the potential impact they may have on the patient's treatment. So, yeah, so the biggest challenge is to provide proper education to everyone regarding these new developments in order for them to make an informed decision. I think this will help us exploit uh, at a great extent these new opportunities and will also help us mitigate the challenges and the risks.
That was a great answer. Thank you so much.
Thank you, Bob.
Thank you for answering all the questions for most of our audiences. I understand this session has kept us well engaged, but there is certain time constraints from our end. So, but I would like to assure audience that we will take your questions and we will email all your answers. You will also be getting a recording of this webinar. So please be rest assured, and we will be sending you all the answers. Can we please go to the next slides? Okay. So last but not the least, I would like to extend my gratitude to everyone. Thank you, Stavros, for presenting today's session so beautifully. Thank you to our audience for taking out your valuable time and attending this session. Today's session has been very insightful. We honestly look forward to doing so many more sessions like this. And I would also like to say that to all our audience, if you have any specific requirements related to multiple myeloma clinical trials, please feel free to reach us out at info@vedacr.com, or you could also go to our website www.vedacr.com. Till then, thank you everyone. Take care. Stay safe. Bye bye.